Welcome to NICU Heroes, a podcast produced exclusively for NICU professionals with me, Catherine Whitaker, as your host. I'm the mom of 6 children, including my very own NICU baby. This podcast is produced by Hand to Hold, a national nonprofit dedicated to providing free personalized support, resources, and community before, during, and after a baby's NICU stay. As a NICU professional, you've been well trained to care for the tiniest and the sickest babies every day. While NICU parent scars are not as visible, NICU parents are often as fragile as their babies, requiring patience, guidance, and encouragement to ensure that they are mentally, emotionally, and physically prepared to endure the pressure of a NICU stay. NICU Heroes is dedicated to helping NICU professionals like you better understand, support, and nurture the entire NICU family. Howdy, y'all. Welcome back to the podcast. This is our final CEU podcast for 2023, and I decided to go out with a bang. So this is a guest that I have had over on our parent-facing podcast, NICU Babies Parent Support, but it is the first time that he has debuted over here on our NICU Professional NICU Hero channel. I think that his experience as a physician and just who he is as a person is going to help you understand better something that probably has landed many of your babies in your NICU. So we are going to be talking about preeclampsia. What is it? What causes it? What are some signs and symptoms? How does it affect babies? I know that it can be a really complex topic, preeclampsia, but Dr. Berry has assured me that he is an excellent teacher, and he said, I can make anything understandable. And I'm not a medical professional. I like to say that I slept at a Holiday Inn and I had a NICU baby. So we learn by osmosis. But I think that his wisdom is going to be such a blessing to you. And I hope that you love today's podcast. So Dr. Berry is my guest today. He is a specialist in maternal fetal medicine, a branch of obstetrics that manages and treats complicated and high-risk pregnancies. He's a native Texan and moved to Austin in 1978. He graduated from the University of Texas, followed by his medical training in Galveston, Fort Worth, and Houston. He was the founder of Austin Perinatal Associates in 1997 and has served the women of Central Texas with complex pregnancies since that time. He is an expert in preeclampsia, critical care obstetrics, cancer and pregnancy, and cervical cerclage, and he is currently employed under Texas Children's Hospital as they expand their footprint into Central Texas. And so with that, let's chat. Well, I'm excited to have you back. I know you haven't been on this particular podcast, Dr. Berry, but I'm happy that I get a chance to visit with you again.
Hey, Catherine, how are you today? I'm so happy to be back. I love talking with you, and I love contributing to Hand to Hold and anything that I can do to make mommies and babies better.
Well, we decided to go out on a bang. So at the end of we've had several great guests over the last several months, but I decided for this very last one that we would tackle a topic that probably lands most women, or at least their babies, in the NICU and probably hospitalizes them. So I thought we'd touch on preeclampsia today, and we're going to dive all the way into it. But first, before we get to preeclampsia, I want people to get to know you a little bit. So why maternal fetal medicine, and why this deep dive interest of yours into preeclampsia?
Well, Catherine, as you may know, that I have been an advocate for women and an advocate for women's health care for now 27 years. I'm now with Texas Children's Hospital, has bought out my practice, but I've been here in Austin, founded my practice in 1997, which seems a long time ago. Were you born then?
I was, and I had been married a year. No.
Oh,
I've been married by then. Yeah.
So, but no, it has been a passion of mine really since medical school. So I was in Galveston for medical school. I decided at age 16, with the help of the mentorship of 2 of my uncles. I had my mom's older brother and my mom's younger brother out of southern Arkansas. Were both mentors of mine back when I was a teenager here at Westlake High School in Austin. And I spent the summers with my 2 uncles. One was a family practice doctor and one was a general surgeon. And so I'd go spend the summers with them. I'd wake up, 5 a.m, go for a jog with my uncle, go get in the shower, get dressed, go and do surgery at 7 a.m. with him and actually assist him in surgical procedures, and then go have lunch. In the afternoon, I would go to my other uncle's family practice clinic. And so I had kind of both the primary care model from my uncle Barry Lee was his name, the same spelling as my last name, but strangely. And some of the kind of immediate going in and solving the problem thing that the general surgeons have. So I kind of got both of the two aspects of medicine very, very early in my career, early in my life. And so then I got into medical school. I couldn't really figure out. I enjoyed primary care. I enjoyed internal medicine. I enjoyed family practice. But I also enjoyed the fact that you could actually do something and solve a problem with surgery. And so both of them were kind of muddled around in my mind until I got to third year of medical school and tried obstetrics. And I was like, oh my gosh, this is the most amazing thing. And we get to help bring life into the world and all this other amazing things. So now I wanted to be an obstetrician, but then I figured I could be an obstetrician that did internal medicine on sick pregnant moms and actually solve problems. And so I went into maternal fetal medicine, and one of the fascinating aspects of high-risk pregnancies and maternal aspects of disease is preeclampsia and all the hypertensive disorders of pregnancy. So that led to medical school that led to OBGYN residency. I found the joy and the love of doing essentially internal medicine on pregnant women. So we take care of anything from diabetes to high blood pressure to cancer in pregnancy, as well as complications from the baby's end, which it could be multiple gestation twins or triplets or quads or quints, as well as birth defects and chromosome abnormalities that we diagnose. So I get to do a little of everything. So that makes my job joyous to go to essentially every day for 27 years. I still love my job.
You still love it. Yeah, you still love. Well, that's.
Yes,
I mean,
ma'am.
and I'm sure that your patients are the beneficiaries of that passion of yours. I love how it was the influence of your family members that sort of led you deeper and deeper and deeper until finally you were like, yep, that's the thing that I want to do. So I know that some people listening to this may know exactly what preeclampsia is and some may have no idea. So maybe let's start there. What is preeclampsia? What are the signs and symptoms if a woman is exhibiting preeclampsia?
So preeclampsia is a syndrome that is unique to pregnancy. Syndrome just means collection of symptoms or signs. So the collection of symptoms and signs is usually third trimester of pregnancy. You start having, they used to call it toxemia of pregnancy. If you've watched some of the old, Downton Abbey shows and such, about the evils of toxemia, and they thought it was a toxic reaction to something. And it turns out that's kind of right. But about the specific, there are hypertensive disorders of pregnancy, which will affect 8 to 10% of first-time moms, maybe even more, depending on your risk factors. Specifically, preeclampsia is one of so high blood pressure or hypertensive disorders of pregnancy is the big kind of big net that includes preeclampsia. Preeclampsia itself is kind of an important, significant part of that hypertensive disorders of pregnancy. So that just means that you have high blood pressure in the third trimester that's unexplained otherwise. Generally, you have pathological swelling of your hands and your face. You have decreased blood flow or abnormal blood flow to your kidneys that can cause organ damage or kidney damage that then is causing you to have protein. So the things that you would see would be protein in your urine, which your doctor would check you for that every time you go in, high blood pressure that's otherwise unexplained, and generally swelling in your hands and your face. So that syndrome can then go to very severe forms of preeclampsia, to one called HELLP syndrome, HELLP syndrome. You can have all kinds of other strange hemolytic uremic syndromes and various other abnormalities of your liver and your kidneys. And I like to think of it kind of in simplistic terms as the best description that I've ever heard for preeclampsia is intermittent regional vasospasm, which is a lot of words. So to dissect it down as intermittent means it comes and goes.
Okay.
Regional means it can happen in areas of your body, meaning it can happen in your brain, it can happen in your lungs, it can happen in your uterus, it can happen in really any in your liver and cause liver dysfunction, happen in your kidneys and cause decreased urine output and even kidney failure. So regional, intermittent, regional, meaning anywhere vasospasm is decreased blood flow. So that kind of describes it in a little bit of a nutshell about what happens and then what you see as a result of decreased blood flow. Decreased blood flow to your brain gives you cerebral nervous system or central nervous system complications and vision abnormalities and flashing lights and cerebral edema. Decreased blood flow to your liver can lead to increased liver function tests and pain in your liver. Decreased blood flow to your kidneys can lead to increased protein in your urine, oliguria, which is decreased urine output altogether. Your urine is brown and you pee just a tiny amount every day as opposed to normal amount. So, and it can include any or all of these things, and it can come and go. So it's also called the great pretender in obstetrics. It can look like appendicitis, or it can look like pulmonary edema or pneumonia. It can look like seizures or epilepsy, and it can look like multi-system organ failure, and it can look like gallbladder disease or gallstones. So it's a great pretender. So you have to really be careful. And when you're third trimester pregnancy, you have to prove to me that you don't have preeclampsia. When you say, my eyeball itches, I'm going to call it preeclampsia until I can prove otherwise. So, but I'm a little, I'm sensitive to that. Yeah.
No. I think women would be grateful and their babies would be too, as if people assumed that it was this very serious thing and then sort of drill down instead of just blowing it off and saying, oh, well, you're probably swelling because it's 110 outside, who knows,
Right.
who knows what's causing that. Yeah. So how do you differentiate between, I'm thinking of Texas this summer and really the heat wave that went over everyone this summer, crazy high temperatures. I was pregnant with our preemie during the summertime, and I felt like I was in the third ring of hell. It was so hot, but even hotter now. So how do you as a physician look at that woman and say, okay, so we know that you are swelling, but we think that's either due to the heat, or we think that's due to preeclampsia. Like, how do you figure that out?
Well, it is. It's a bit of a puzzle every time. And I use every single patient and look at her individually. I never look at someone and say, oh, well, you're just like every other patient and you're just, hot and swollen and angry because you're pregnant.
Don't say that to a pregnant woman.
No, but that's, you get classified and you get pigeonholed into these little, it's so hot, so therefore, XYZ. I was like, well, that may be true, but could you have preeclampsia as well? So we do have to, for instance, a hot day will make you kind of irritable, but once you calm down in an air-conditioned setting and take your blood pressure, your arm at the level of your heart, sitting, resting for a few minutes, find your, quiet serenity space, and then check your blood pressure. The outdoor heat's not going to affect that. The outdoor heat is not going to affect protein in your urine when they dip it. The outdoor heat is going to make you more dehydrated, more prone to sweating, more prone to, decrease urine output, especially if you're not drinking enough, dehydration and such. But that's our job to kind of differentiate that. So that would be the first step is find a quiet space. I recommend frequently for my patients to get a normal, kind of normal adult, sometimes adult large blood pressure cuff for home, not one of the little wrist cuffs that some people put on the wrist. But those are okay. But a general, blood pressure cuff, and check it at home when you have kind of quiet time and nothing's going on and the kids are in bed and the TV's off and your phone's off and your husband's, busy doing something else, then, find a quiet spot, rest and take your own blood pressure at home, because that's going to tell us what's going on. Some of the time, it's not 100%, but it'll tell us it's a good hint. And when we're putting together a puzzle like this, we need little hints and hints and hints, and it will come together exactly what's going on.
So you're primarily looking for swelling, high blood pressure, protein in the urine are sort of the three big things that you focus on when trying to figure out. And then obviously drilling down, what do we think is causing this? What's the cause of that? If a woman comes to you, Dr. Berry, and she does have preeclampsia, like you've determined, okay, this woman is definitely has hypertension and we think that it's also preeclampsia, what do you start monitoring in regards to the baby? Like how do all of those things, aside from, yes, it's possible that she may deliver early, is there anything else that's going on in utero that would have you concerned?
Yeah, absolutely. Once you have the diagnosis of any of the gestational hypertensive disorders or preeclampsia, then you have to differentiate, is it, kind of low grade, simple gestational hypertension, mild preeclampsia, or more severe? The severe preeclampsia, you can kind of group all together based on, is it affecting an organ system? Is it causing what they call end organ damage? Meaning, is your liver being affected? So we might check your liver function tests. It's just a blood test for what's called an AST or ALT. They're just they're enzymes that are inside the liver cells that are unique to liver cells. And when liver cells start dying, those enzymes in your blood will start going up. Same thing will happen. They'll check your cardiac enzymes when you have a heart attack. Your heart attack, you damage your heart muscle. There's some enzymes within the heart muscle that in the cells that are unique to heart cells. Once they start breaking and dying off, the enzyme goes up in your blood. So that's liver function tests. Sometimes we'll draw blood. We'll look at your platelet counts. Sometimes one of the first things that we'll see is actually an increase in your hemoglobin and hematocrit. So you get what's called hemoconcentration. So that means you're leaking fluid out of your circulation, and that's what's causing that swelling and edema. You're leaking more fluid into your urine and more protein in your urine, but you get an increase. Normally people get anemic during pregnancy. All of a sudden somebody's hemoglobin is 10 or 11, and all of a sudden at third trimester it goes up to 13. It's like, well, why? And that's missed sometimes. Some doctors don't look at that, but I'm kind of very wary of looking all kinds of aspects. But then once you have end organ damage, then that's considered severe preeclampsia. That's a cause for delivery. But back to your question is, what happens to babies? The uterus is an end organ. And so regional vasospasm happening in the uterus cause decreased blood flow to the uterus, decreased blood flow to the placenta. Guess what? Baby needs that blood flow for the placenta to work, to continue growing, continue the baby putting out urine, which is the amniotic fluid. So if you have decreased blood flow to the uterus, you'll have low amniotic fluid sometimes and babies that stop growing. And so it can be dangerous to the babies. We've seen sometimes that's the first sign of preeclampsia is small babies and low fluid. Sometimes it's seizures, sometimes it's pulmonary edema and what looks like pneumonia. So it can look like anything. But yeah, once you have the diagnosis of preeclampsia, we have to say, okay, look at the kidneys, look at the liver, look at the baby, look at your lungs, look at your brain, look at all of these symptoms.
Look at everything.
And then if anything goes wrong, you've got the diagnosis severe preeclampsia, and then we're kind of on the verge of delivery.
Well, I'm thinking now, it's interesting because so we had IUGR, intrauterine growth restriction, as well as low amniotic fluid with my son. And I remember them being upset. I remember them being obsessed with my blood pressure and, the proteins and all of that. I mean, he was born early, obviously, but so when a woman does get to that point, so I know many women will carry mild preeclampsia, through their entire pregnancy with really close monitoring. And then some of them, like you said, it starts to move into that severe category. When, Dr. Berry, do you decide, okay, this baby has to be delivered today, or as long as we can keep these things in check, we feel like we can let the baby cook a little bit longer? Like, how do you make the decision when you need to move forward with delivery and when you need to keep trying to keep the baby in utero?
Right. And we do have actually two patients right now. Neither of them has preeclampsia, but both of them have a placenta that's not functioning. So from the baby's point of view, we look at, how, number one is gestational age. Where are you now? If there's a threat to a preterm delivery, the first thing I do is give steroid shots. So the what's called betamethasone is the steroid shots that you'll hear in labor and delivery. Oh, did you get your steroids? The steroids help mature the baby's brain, lung, and intestines by about 2 weeks in time over the course of 48 hours. And that persists for about a month, about 3 to 4 weeks. So that we're actually watching two babies right now. Again, it's not preeclampsia, but it's placental dysfunction. And what we're doing is waiting. When the baby just, we're playing chicken with a train, an oncoming train, and we're sitting there waiting. If we get off the train track too early, then the baby has more problems with prematurity. We wait too late, then we lose the baby, and the baby can die inside. So we're really playing with lives here, and so we can't afford to be wrong, really. So with ultrasound is our key to monitoring the baby. We do the non-stress test, like the labor and delivery monitors for non-stress tests. Baby's arm and leg movements, body movements, breathing movements, and fluid volume is what's called a biophysical profile. And then I look the primary things that I look at with babies that could get into trouble is their growth stopped or so far behind, the amniotic fluid low, and then what's going on within the we can do placental blood flow through the umbilical cord. We can look at velocities. It's like a police radar. How fast is that blood going through the artery? And if it peaks and valley, it's like systolic and diastolic blood pressure when your heart pumps and when it relaxes, when it pumps and relaxes. So we're essentially doing almost like it's not really blood pressure, but it's a blood flow from the baby to the placenta. And once that blood flow gets very difficult for the heart to beat and no blood flow at return, while it's relaxed and getting ready to beat again, that's putting a lot of strain on the heart. There's sometimes where the blood flows forward when the baby's heart's pumping and then pumps backwards the wrong direction through the artery toward the baby's heart. And that's a baby that's within 24 hours of dying. Those babies have to get out right away. So I frequently send patients, you're going to come in twice a week. You're going to see me. We're going to do ultrasound twice a week. And one of those times, I'm going to send you directly to the hospital for a C-section. So that's our fetal monitoring portion. But then the mom monitoring portion, what's going on with your liver, your kidneys, your platelets, what's going on with your urine output, how's your brain doing? We have to do that assessment almost daily and teach the parents to watch for, right. Everybody talks about visual disturbances in preeclampsia. It's not visual. It's not floaters. Everybody has floaters. Everybody has, increased risk of blurry vision. It's not blurry vision or floaters. It's bright, flashy lights. It's the lightning bulbs going off, the flashing light, the flash bulbs going off in your vision. When you have that, usually you have really severely high blood pressure. So when people talk about visual disturbances, it's not blurry vision or floaters. It's flashing bulbs going off in your vision. If that's happening, you need to have your blood pressure checked right away. And this can happen over the weekend, can happen in the middle of the night. Once that thing happens, I tell my patients, whatever the next thing is, you call me, you're going to go to the hospital. So the next thing is, I tripped over the cat. Almost anything I'll look at, that next thing they're gonna go to the hospital because they're gonna call me. I've got the worst headache of my life. It won't go away with Tylenol. It won't go away with eating or drinking or resting. That's going to the hospital. I've got now the screaming pain in my liver and my right upper quadrant feels like a gallstone attack. I'm doubled over and can't breathe. Every time I breathe, it hurts. So it's really, most of the things are not very subtle. Most of them are very severe, of severe preeclampsia are pretty obvious.
As you were walking through all the biophysical profile and watching, I just was like, so he's basically describing my entire pregnancy with our son. And I mean, I
Right.
think I knew to some degree what they were looking for, but I had some heart issues and now it all makes sense as to my body was working just as hard as that baby was to try to figure
Right.
out, can we get to term? And you've got two people really trying to get it together. And when one struggles, it affects moms. We always say that we can feel when our kids hurt, even when they're out of our uterus. And
Right.
but something's wrong. Um, that's fascinating. So, Dr. Berry, so with your patients, do you typically? I know you were talking about what's the next thing. So, like if they're exhibiting symptoms of preeclampsia, and okay, so they haven't had the flashing light, for example. Are you telling them, okay, if you see X, Y, and Z, you need to call me? Are you telling them these are some things that you need to be looking for? And if you see those, that means that we have moved into a new level of seriousness, and either you need to come into the office or we need to send you to the hospital. How do you prepare, I guess, your patients for knowing? Not freaking them out, but giving them an idea of what's possible to come and how serious it might be.
Well, I think knowledge, people say knowledge is power. That's kind of an interesting way to put it, but it's actually really true. If you paint, and I paint pictures for my patients, I tell them, like, for instance, moms that are this one mom that I'm seeing this week has a 1 pound, 5 ounce baby. The baby's probably not going to grow beyond 2 pounds under any circumstance, probably is going to have to be delivered by 28 or 29 weeks. And I tell her, what does that look like? What does it look like to have a 1.5 pound baby? What does it look like? What does the babies come out? They have some more maturation because they're smaller and they're mighty little babies. For moms that have preeclampsia or babies that are growth restricted, they're mighty little tough critters. But what is 6 months in the neonatal ICU? And I paint the very, very clear picture. And once patients have that picture, they don't have anything to fear. I mean, those are things that you don't want those things to happen, but the absence of knowledge, I think, and the absence of knowing what to expect the unknown creates more fear than the known.
Right.
So, devil you don't know sort of thing. But to paint a picture of, okay, this is what would happen. Hey, I expect, and I'll tell patients, I expect you have mild preeclampsia and you're now 32 weeks. I expect you're going to deliver in the next 2 weeks. I expect this to happen. I'm looking for this to happen. Watch for changes in your vision, particularly the bright flashy lights, horrible, horrific headaches, not just I have a little,
Right.
sinus headache or a little, tension headache. It's like, this is doubling over severe. Somebody hit you in the head with a 2x4 headache and won't go away. I mean, so they're not subtle. So I tell them, very specific things to look for. Once you start peeing and you look in the toilet and it looks like there's Coca-Cola or somebody just poured iced tea in your toilet bowl, that's the problem. But I tell them very specifically what to look for, where they would see it, when would they see it. I'll usually frequently give them a timeline within X number of days. I tell some patients within 2 or 3 days you're going to have to deliver. But once you get that close, frequently I'll put you in the hospital, because the stepwise approach is, you have a risk factor. That's one thing, but now you have it as number 2 in mild form. Now bed rest or stay at home or watch or home blood pressure monitoring, frequent visits to the doctor. The next thing is hospitalization, and the next thing is delivery. And that's regardless of gestational age. We've had to deliver. I delivered a physician at 20 weeks from severe preeclampsia. She wasn't even third trimester. In the ICU at Seton Medical Center, the baby couldn't survive. The baby was, literally about 9 ounces, but the mom was about to go on dialysis because she was in liver failure and kidney failure. So these can be very extreme cases to the point where the baby can't survive. But it gets really dramatic. When the younger the gestational age, the more dramatic it can be.
Well, I'm actually really glad that you said that you prepare your patients. I think when I look back at whether it was a nurse or a specialist or a therapist that was saying, not that they were diagnosing in the sense that like this is what is going to happen to your child, but these are some things that you should consider, or this is what it could look like. I felt like I sort of had a baseline, and then I could say, okay, if my child exceeds that or we fall below, I sort of knew what was coming. And I think it made me less anxious to know, one, that it could be better or it could be worse, but knowing sort of where we are and what could happen, and not like the dire, like, let's go through the 50,000 things that can go wrong with your NICU baby.
Right.
But
Right.
hey, your child has this particular thing going on. And so these are some of the things that we might see. And it almost puts another set of, nobody knew my baby and nobody knew my body better than me. So for me to sort of know these are some things that I should look for, I was the one that was going to see them first or feel them first. So, and then translate that to the doctor, and then we can figure out where to go from there. But I'm glad that you mentioned that.
Right. Well, and you're the, I don't know, you're the lookout on the wall, for instance, of the castle. Who's going to see the danger first? It's going to be the person looking out into the darkness on the wall, on the tower in the middle of the night. Well, who is that? Well, that's you. That's you, the patient. And until or unless you're well educated, I want you to know as much as I know. I don't want you just to kind of go, oh, well, the doctor said blah, blah, blah. No, I want you to know it and feel it and understand it. And so because you are the watchman.
Well, it's better to hear it from you than it is from Dr. Google. So you're a much more reliable source.
The important part for Dr. Google, it's about 90% correct. I mean, for general information, it's right. For your specific information, for you specifically, is it complete? And it's not complete. It's hey, what's preeclampsia? Third trimester blood pressure over 140, systolic over 140, diastolic over 90, more than 2+ proteinuria, or more than, it's 300 milligrams in a 24-hour urine collection, blah, 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 but what does that mean to you? Right. And until or unless you know what is a 24-hour urine collection, what is, non-nephrotic range proteinuria, what are all these, what is HELP syndrome, what's a liver enzyme, what are all those things, what's a platelet? You don't necessarily know all of so it's not complete information, but it's actually good baseline information. If you want to know what's up, it's a good source to have. I'd rather much rather have a patient bring me a list of questions off of Google than to not. And find your question, write down your question. I've had patients with whole books of questions because they got off of Google. I'm happy to do that. Now, if your doctor isn't happy to do that, you might want to look into a new doctor, because they should be. That's our job, is to listen to the watchman on the tower and to see when there's a problem and to intervene. We're the king of the maybe the king of the medical establishment. We're controlling your access to the medical establishment, whether it's intensive care unit or C-section or ICU or whatever that thing is. We're then the filter that gets you, the watchman, into where you need to be.
My doctors got so used to me asking so many questions, they would just come in and sit down. So it's okay.
If your doctor doesn't sit down with you, if they stand with their hand on the doorknob on the inside,
I remember looking at them saying, "I'm going to need you to sit down. I got a lot of questions, so here we go."
I don't think I've ever had a patient encounter out of 200,000 patient encounters over 27 years. I don't think I've never not sat down. I don't think I've ever stood up during a visit. So I love my patients.
I think it was like when they would be rounding, and right. I was like, "Hey, I'm just going to need everybody to have a seat," and I would pull out my 2 pages of questions and be like, "Here we go, everybody, get Good. A cup of coffee, let's do it." But
you're the informed consumer then.
Well, I wanted my baby to leave the NICU, yes. and I loved him a lot, and I know they did too. And so I think that a parent who questions is one who really wants best for their baby, and sometimes that parent doesn't know what questions to ask. So hopefully, right. as we sort of walk through all this, maybe there's a NICU professional listening to this and thinking, maybe I should, give them more information or help them through this so that they can be more informed and be a more involved parent. I know that you mentioned the HELP syndrome, and so I think, if you don't mind, I'd really like to dive a little bit into that, because sometimes people use preeclampsia and HELP interchangeably, and right. so I want you to kind of help us understand what the differences are between the two.
Well, this is where I kind of need my whiteboard. I should have, here's my whiteboard, and here's
this is when YouTube comes in handy.
YouTube is very, very handy. So HELP syndrome is one of the subsets of preeclampsia, or one of the subsets of hypertensive disorders of pregnancy, that is one of the forms of severe preeclampsia. So if you have HELP syndrome, you have severe preeclampsia, or a form of severe preeclampsia, or severe hypertensive disorder of pregnancy. So what is HELP? HELLP stands for, number one, H, everybody thinks is hypertension. It's not. It's hemolysis. It's your red cells being attacked in your microcirculation of your capillary networks in your body. The red cells are getting sheared and broken apart and essentially dying off. So you get anemia from a hemolytic anemia. It's a transient, meaning it comes and goes, or a transient meaning it's temporary and it goes away while you're pregnant. Once you deliver, the inflammatory process in the small blood vessels of your body stops, the inflammation stops, the breaking down of the red cells stops. The ESO, HELLP, H is for hemolysis, EL is elevated liver function test, or EL is the elevated liver. That's that AST and ALT, the enzymes, where your liver is now, your red cells are being damaged, your liver is being damaged. LP is low platelets. Platelets are the clotting factors, or little clotting cells that come out of your bone marrow. So comes out of your bone marrow whenever you have inflammation or damage to something. Say you cut yourself or whatever, then the platelets are the coagulation cells that stop the bleeding. So they're being eaten up. Essentially, you're having inflammation in your small blood vessels. You're having tiny little microclots being formed, and luckily dissolving, but some of them are formed and blocking off the circulation to parts of your brain, your liver, your kidneys, things like that. So that's an intense inflammatory process going on in your circulation. And so that one is the only one you can't really diagnose that HELP syndrome without the assistance of the labs. The CBC is a complete blood count, looks at your red cells, white cells, and platelets. And then what's called a metabolic panel, or a liver function panel, that looks at your AST, ALT, and C. So this is just kind of what's being damaged. Your red cells are being damaged, your liver's being damaged, your platelets are being consumed unnecessarily. You've heard things like consumptive coagulopathy. That's where your proteins, your clotting proteins and your clotting cells are being used up unnecessarily, and then they go away. And then guess what? You don't have enough clotting cells and clotting proteins to clot normally. And so you tend to bleed. and bleed from all kinds of places, bleed from your GI tract, bleed from, every orifice essentially.
So when you're talking about damage to the liver or really any of the other organs, is that damage when it becomes HELP or a severe form of preeclampsia, is that damage irreversible or is it reversible?
In the early phases, it's reversible, but you can actually go into overt kidney failure and go into overt liver failure. The liver is very forgiving and rebuilds itself. Kidney cells are not quite as good. They usually scar up, but you have a whole lot of nephrons, a whole lot of kidney cells that are there. So you have extra. Same way you can donate a kidney to your sister if she's had some sort of injury or problem, and you're fine and she's fine living with one kidney. So our kidneys kind of have more function than we need. So they're a little bit more resilient to damage. The liver's a little more resilient to damage and can rebuild itself. And young, healthy, pregnant patients have a lot of blood flow and a lot of ability to cure them and heal themselves. So thank God for that. But yes, those are the things that are being damaged. And if left to their own devices, you can go into overt renal failure. You can go on dialysis the rest of your life as a result of HELP syndrome or preeclampsia. You can die from liver and kidney failure for sure. So those are very serious things that, again, you frequently will be in the intensive care unit.
So if you have a patient who's been diagnosed with preeclampsia, then it becomes a situation where you believe that she also has HELP. Is that immediate delivery or is that constant monitoring? Like when someone has HELP, how serious? And I'm sure that there are varying degrees, but
Right.
in the realm of what you do in obstetrics, how close are you to the ER and delivering to the OR, and delivering a baby if you have HELP?
There are different layers, like you said, different levels of HELP syndrome. Because you beam out the baby and get the baby out right away, you're still going to have this HELP syndrome residual for 2, 3, 4 days. Okay. So getting the baby out in 5 minutes versus 5 hours doesn't really make a difference. But once you have HELP syndrome, you really need to be on the road to delivery. If it's mild and you're 32 weeks, go ahead and do your 2 steroid shots and get your induction started 48 hours from now and deliver in the next 3 to 4 days. If you've got significant HELP syndrome, put you on magnesium, put you on Pitocin, try to get a vaginal delivery if your cervix is ready and available. Try to get 48 hours of steroids on board if you can, if you don't have that luxury. Because steroids actually, the benefit of steroids is they can actually reverse some of the signs and symptoms of HELP syndrome. They can reverse some of the inflammation. They can reverse some of the liver damage, and they can bump your platelets up. So the steroids are not only helpful for the baby's lungs and brain and intestines, if you have the luxury of the time, but it's also helpful to the mom. So helpful to the mom and helpful to the baby. So in fact, we've had, this was 20 years ago, we were administering IV steroids to a patient with severe HELP syndrome and trying to do induction. Well, 12 hours later, 18 hours later, in the middle of her induction period, her platelets were normalized and all of her liver function tests went back to normal. It's like, hey, she's cured. It's like, no.
No, it's the steroids.
No, she's temporized. She's not cured. But one of the doctors actually at Seton Medical Center was this 25 years ago, said, oh, she's cured. Let's not do her induction anymore. I was like, well, I mean, that's a good thought. Hey, she's cured. We fixed her. But the problem is you've transiently fixed her. And once her platelets go down after steroids happen, you can't get them up.
Right. The crash is gone. You can't.
Yeah, you're done. So once you're diagnosed with HELP syndrome, you have to deliver. Is it a day or two or an hour or two? But some doctors will panic and go, oh my gosh, we have to do a C-section in the next 3 minutes to get the baby out. Well, not really. If you're doing it for mom's sake, just take your time, make your decisions, make a reasonable decision, get neonatal ICU to do the consult with the patient, talk about it, think about it. If she's eaten in the last 8 hours, let her, wait 8 hours, get her on magnesium, get her steroids started for her and for the baby, and then kind of go forward from there. If you need to do a C-section in 3 or 4 hours or 5 hours, that's fine. Mm-hmm. But the whole, fur flying, stat C-section, oh my God, everybody's, that's not necessary. It's not going to fix it for mom just by getting the baby out. It'll get her on the way to recovery.
Right.
But it doesn't instantly getting the baby out makes the obstetricians feel better because we don't have to deal with the baby anymore. we just deal with the mom, right. But it doesn't really help the mom, and it doesn't really help the baby. If you have the luxury of a day or two, 1 or 2 doses of steroids is better than none.
Right. Yeah, this is not Grey's Anatomy. This is real. This is real hospital stuff.
Right. Grey's Anatomy is cramming like 2 days of stuff over the course of like 10 minutes.
Right.
And so
Yeah, exactly.
all those things do happen, but they happen very slowly.
On a different timeline. So,
Yes.
Dr. Berry, I'm curious. So if a mom has preeclampsia, she delivers her baby, do babies of moms who have had preeclampsia, do they exhibit certain characteristics that you may say, oh, I know that baby's mom had preeclampsia because I'm seeing XYZ in that baby? Would you see some things that might give you an indicator?
Well, the interesting thing that happens with moms who have babies with preeclampsia, especially if the babies are growth restricted, like you were saying, you had low fluid and growth restriction
Right.
with your baby. When babies are under stress, that's an intrauterine stress. They don't have quite enough blood flow. The placenta is not really working very well because there's not enough blood flow to the uterus. But for whatever reason, if babies are small and a little bit stressed, so stress is okay and actually good, that helps mature a baby. Distress is not. So you don't want a baby in distress. You want a little bit of intrauterine stress will help mature a baby. So if you have, I'll give you an example. One baby had a patient who had twin girls. So one of the babies was perfectly fine, growing 50th percentile. The other baby was like a third the size of big sister, and they weren't twin transfusion or any of that. It was fraternal twins, two placentas, two babies. One of the babies was tiny. So we got her, we kept going, doing these studies, these biophysical profiles and blood flow Dopplers and stuff at the office, steroids, knowing this one baby was going to have trouble. Got her out to 32 weeks. That one little baby just couldn't handle it anymore. We had to deliver her. The blood flow was just deteriorated to reversed flow. Delivered both babies. The little so it was 32 weeks, 4 pound, 4 ounce twin girl. She was just lying there floppy and didn't want to breathe on her own. Had to have a breathing tube put in at 32 weeks, the 4.5 pound baby. The little 15 ounce little sister sitting there screaming and crying and grabbing things and throwing them on the ground. And the neonatologist at Seton Medical Center told me he was a little kind of, I don't know, he didn't know what to think. But he said, well, we intubated baby A and she's fine. And baby B is 15 ounces. And first one's 4 pounds, 4 ounces, little 15 ounce one. I wanted to try to intubate her, but the baby wouldn't let me. She grabbed the endotracheal tube 3 times and threw it on the ground and wouldn't let him intubate. And she had 100% oxygen saturations. So babies that are stressed,
ounces.
15 ounces didn't need a breathing tube. So preeclampsia can actually help baby. Well, it doesn't help them mature them. It causes intrauterine stress. Then that helps mature them. And then if the babies are a little small and low fluid, they have more intrauterine stress. So that matures them. So it's not the preeclampsia itself, but the decreased blood flow to the baby can actually be a maturing thing. But it also restricts their growth. So
Right.
Good idea, bad idea sort of thing. But the little baby, if you tell me a 32-week baby came out and weighs 2.5 pounds, I'd say, well, does the mom have preeclampsia? Oh yeah. How'd you know? The baby doesn't need any ventilator or doesn't need a whole lot of oxygen or a lot of support. I was like, oh yeah, that kind of makes sense. So for me, it makes sense to have babies that essentially, it's not all the babies, but they essentially, as a group, tend to be a little bit more mature. So you might have a 32-week baby that's acting like a full-term baby, but that's because of the intrauterine stress because of the preeclampsia.
Well, we always used to say that if your baby's being feisty, if they're kicking out, their IVs or they're yanking on stuff, that's a good sign because that means that they feel good. They want to get the stuff off of them.
Right.
But yeah, I remember looking at my neonatologist and I was like, do we strap him down to keep his IVs in or what do we do here? Like he keeps kicking them out, that little stinker.
Or do we just feed him? And
or that too, yeah. It just meant that he was starting to feel better. I know in the news, sometimes it feels like, maybe it's because we have more access to information, but it feels like there is a rise in preeclampsia. Do you think that the rise is due to us just having access to more information and hearing about women having preeclampsia, or do you think there's an actual trend of no, more women are actually exhibiting signs of preeclampsia? And if that's the case, why do you think that is?
Well, I was looking at a study that was done, I believe it was an NIH-funded study that looked backwards all the way back into the 80s and from 1980 to 2022, I believe, to see what's the trend in preeclampsia. And overall, I mean, they say of all the hypertensive disorders of pregnancy, they're quoting, 8.7% incidence. I kind of round that up and tell patients there's generally, with first-time moms, first pregnancies, there's generally about a 10%. It's a little less than that, but I round up to a 10% chance of high blood pressure preeclampsia if you have no other risk factors. And if you've had a baby before and have no other risk factors, then with the same dad, by the way, it's kind of an interesting part of preeclampsia. It's called a new sire syndrome. But so if you have a subsequent baby, second, third, fourth baby with no other risk factors, it's more like 5%. But I use preeclampsia. It should be any hypertensive disorder of pregnancy. But specifically, preeclampsia stayed about 3.5–4% across the board. You'll see little segments where, and preeclampsia is an interesting disease. It happens in patients that are very young, 16, 17-year-olds, 15-year-olds that get pregnant, have a 30% chance of preeclampsia. 45-year-olds have, somewhere around 30–35% chance of preeclampsia. But so it's at the two extremes. So, the extreme, they call it extreme ages or extreme maternal gestational ages, your teenage pregnancy and your 40-year-old pregnancies. So I think we're having more 40-year-old pregnancies because of IVF and things like that. So statistically, we're having a few more of that. But I think it's, generally speaking, it hasn't really changed. We're seeing, I think we might be seeing or observing that, like you said, our information is better. And we know about that. And now not just, the general public knows about it, not just the obstetric community, but the general public knows. It's like someone died of high blood pressure and preeclampsia and, Seton Northwest, whatever the hospital is. It's shocking that it happens and now everybody knows it. But as far as the actual incidence, I don't think it's really changed much. Generally, they say like 8.7% of the total population.
So you said something that I want to go back to. So you were talking about the new sire syndrome. So let's talk about the dad's role here. They have got no press today. So let's give them a little bit of press. So what do you mean?
So it's called a new sire syndrome after, a dog is a sire, so it's very strange. And we think preeclampsia, the origins of it are actually, if we transplant you with a kidney that's 50% foreign, you're going to reject it. Your immune system's going to reject it pretty quickly. If we transplant you with a fetus into your uterus that's 50% foreign meaning half your DNA and proteins and half, quote, foreign, half dad's DNA and proteins that's unusual, that's not normal for your system to have. But you're fine 90% of the time, 95% of the time you're fine. It's like, well, why is that? That's very strange. So there's an immune suppression that happens with pregnancy. And then that immune suppression breaks down in some women and causes preeclampsia. So if we could figure out what caused the immune suppression and what was effective in immune suppression, and then why does it break down, we would cure preeclampsia. So we don't really, there's higher levels of cortisol and some of these anti-inflammatory steroids. You have a natural immune suppression pregnancy, but why do you have the breakthrough with some patients and not? But we think it's a breakdown of your immune system's tolerance to the baby. So the baby's foreign to you. Say you have 2 or 3 babies and then, I don't know, you have a divorce or lose your husband, you get remarried, you have another baby with a new person, a new sire, then your risk goes from, it was, 10%, 12% for first-time moms. Then it's 5% or less for second, third, fourth babies. You have a new dad come in, it goes up to that 12, 14, 15% again. It's like it's the first pregnancy. It's like,
I was going to say, like it's all over again.
Yeah, you're starting again. So the theory is that once you have been exposed to those paternal antigens with first baby, then second, third, fourth baby, it's less likely that you'll have a problem. It's like almost getting, I don't know, your cedar fever shots. We expose you to a little bit of cedar and or drops under your tongue. We expose you to the allergens, and then your body makes you more tolerant. Your immune system more tolerant. So having a baby or two makes you more tolerant to those antigens. Have a new dad with new antigens to have a baby, then you're back to kind of square one. So for instance, I see a patient that's their 4th or 5th baby, and now she has horrible preeclampsia. I was like, is this a new dad? And almost always they'll say, how did you know? they're offended, or they're offended. It's like, what do you mean? What do you mean?
Have you been stalking me on Facebook? No. Okay. So I have a question. So I had 6 babies, and it wasn't until same dad. It wasn't until my fifth baby that things kind of went haywire. But I was 34 when I got pregnant, 35 when I delivered. That's interesting to me that after having all those babies that I still exhibited signs, 5 babies in. I mean, I guess was
Right.
I maybe closer to the 40? Who knows,
It could
right?
be. It could be. I would ask you. I mean, not to get personal, but I would ask you as a patient, are you exhibiting any signs of autoimmune type disorders? Things like lupus, things like hypothyroidism, which is Graves' disease, and Hashimoto's syndrome will cause low functioning thyroid. A lot of women have low functioning thyroid. So yeah, I would get into that with you and talk to you about, are you having any of those signs? Because it might
We'll have to do this at the end then. This is fascinating.
Because if you start having an autoimmune type syndrome, like a lupus patient is 6 times more likely to get preeclampsia.
Wow.
Someone with pre-existing high blood pressure has a 2 to 3 times higher chance of getting preeclampsia. So it's all of those things. So pre-existing vascular disease, if you've had a kidney transplant before for vascular disease, you're like a 5 or 10 times higher chance of getting preeclampsia. If you have twins, it's twice as high. Imagine I'm 40 years old, I'm a first-time mom, and I'm doing donor egg IVF and have twins or triplets. So now the babies are not only 50% foreign, they're 100% foreign to your body because they're donor egg and donor sperm, or somebody else's sperm, somebody else's egg in your body. Now it's a complete mismatch. And now you got 2 of them, and now it's a first baby. And now I tell those patients that you have a 100% chance of preeclampsia. Don't know when you're going to get it, but you will get it. And they get it. They always get it. I think I've had one patient in 27 years that had kind of similar, risk factors that didn't get preeclampsia. So maybe 99%. I should amend my recommendation.
Nothing's 100%. Yeah.
But yeah, just having, later on in life, you're more likely to have pre-existing high blood pressure, diabetes, lupus, autoimmune disease, and those all increase your risk.
Right. Oh my gosh, that's fascinating.
Those are the things I would ask you if you were my patient.
If I was your patient, we'll do that at the end. Well, speaking about just incidences of preeclampsia and where you see them, I know that especially in February, I think it was February, we did Black Maternal Health, in April, we did Black Maternal Health Week. And I interviewed a friend of mine. She has quads. They were spontaneous quads, which is fascinating. And they're all doing beautifully. And she spent no time, if you can believe it, I think they spent 2 days in the NICU.
Wow.
So
crazy.
Really, really crazy story, but also pretty awesome too. But she was talking about as a woman of color walking into her maternal fetal medicine doctor office and not feeling seen at all. And she said, but yet I had, people around me who were good supporters and helped me sort of navigate the system. So she had things in place. But you also hear about women of color who maybe have a higher incidence rate of preeclampsia. Dr. Berry, do you think that that's because they don't have the support, they don't have the access, that they are more prone as women of color to develop preeclampsia? Where does that fall in the line when you're diagnosing preeclampsia and it's a woman of color? Is her incident rate higher, or what factors sort of contribute to that?
So women of color do actually have a slightly higher incidence of preeclampsia and all the hypertensive disorders. When they get it, I have seen the severity much more severe in certain women. And again, this is a small subset. But just in general, yeah, I consider that a separate risk factor and watch patients more closely. I don't think it's necessarily access to care. I know there's a lot of argument about access to care, but as an obstetrician, we diagnose it after it happens. So something happens, then we diagnose it. So maybe the delay in diagnosis could certainly be an association from socioeconomic status, access to care, that sort of thing. You might delay the diagnosis. Information might be a little more lacking, but I don't think it's. And certainly with the Black community, there's going to be a slightly higher risk of it and slightly higher risk of severe disease. Right. But no, I think we as obstetricians, we're reactive. We're not very good at proactive. We have not prevented preeclampsia. We haven't changed the rate of preeclampsia. The access to medical care, access to hospitals, access to tertiary care centers that can treat it, that allows us to treat it better. So the maternal aspect, maternal survival is better, baby survival is way better, but the actual occurrence of preeclampsia doesn't change one way or another. I don't think we're just kind of the secondary people said diagnosing it. We're not called, the access, say you had great health care, is that going to prevent preeclampsia? Answer, absolutely not. If you had no health care, was that going to cause preeclampsia? Absolutely not. It's going to be the same either way. Yeah. We're just diagnosing it. So it's the access to care would delay the diagnosis sometimes, but and that's where education could come in. Right. But I don't think that that's a kind of an inherent, not something inherently because of access to care is causing preeclampsia, so to speak.
Yeah, I think in her case, it was more she was sharing signs and symptoms of preeclampsia and her doctor wasn't listening. And so that's a case where you either say we need to get a new doctor, we need to get other people in here, to continue to be good support network. So
yeah, and that's probably a doctor problem and not a race problem. That's that individual doctor. Like a quadruplet pregnancy, we would be seeing in our office, we'd be seeing her once a week from 28 weeks on, in addition to the obstetric office. So we would be watching for preeclampsia. We would be watching for any of the hypertensive complications, because she would be at just take 8% times 4 babies times 4, that 10% times 4, it just round up 40% chance she's going to get it.
Yeah,
that's almost a 50-50 chance. Yeah, surprise.
Yeah,
I wouldn't be surprised at all. Of course she has preeclampsia.
Yeah. So I'm going to ask you to dream a little bit. I usually ask this as my last question. And you kind of alluded to it a little bit. Like, what is your hope, Dr. Berry, over the next 10 or 15 years? How we diagnose and how we prevent preeclampsia. If you could dream a little bit, what are some things that you hope we might see in the next 10 to 15 years when it comes to preeclampsia and lowering the incidence and making the outcome less severe?
So it's very frustrating to me as an obstetrician. The things that we deal with as obstetricians is preterm labor, preterm delivery, ruptured membranes early, and preeclampsia. And in the last 100 years, we have done nothing to prevent it. Nothing. We can tweak along the edges with baby aspirin and calcium and omega-3 fatty acids for the higher risk patients. And that'll help delay the onset a little bit and lessen the severity a little bit. But as far as preventing it, we haven't done anything. We used to, the early 1900s, we would bathe people in Epsom salt baths. Well, Epsom salts is the same as magnesium sulfate that they inject you with. So we've gotten so advanced, we now no longer bathe you in Epsom salts, we inject you with Epsom salts. Hooray, win. But that's just at the very end to prevent seizures and that sort of thing. But no, my dream is that we actually decide to look at what is the thing that causes it? What is the thing that prevents it in women? How do we enhance that system in women that are at higher risk for preeclampsia? How do we prevent it? How do we, there's some studies that are done mainly, I think, out of Europe that are taking paternal antigens, paternal white cells, and injecting it into the mom ahead of time, injecting it into your skin so your body gets used to those paternal antigens. Is there something that's missing? But we can, once we figure out what causes the immune tolerance in most women, we will, in fact, cure preeclampsia. We'll get a Nobel Prize sort of cure preeclampsia worldwide. And so how can we do this? And it has something to do with either suppressing the immune system of moms further or regulating that somehow, or immunizing you to the foreign antigens that are, what your baby carries from dad. So if we can immunize you from that, we would prevent preeclampsia 100% of the time.
And close down about half the NICUs. Because
exactly.
those are...
And so that's another thing we'll talk about later. Cervical cerclage, sewing up a cervix, a 5-minute procedure to prevent preterm delivery. We go from the 12% prematurity down to 4% in super high risk women. So I would do that too. I find a way to easily cerclage every patient and immunize you from the dad's input into your system for stimulating your system to respond. So if we
and you would eliminate an entire specialty, like an entire neonatologist would be out of a job.
That's right.
Which would be great, right?
I put myself out of a job, and I put the neonatologist out of a job. So they might not like me for that. But no, my dream is to actually make a difference. I had a corporation called Obstetric Technologies. We found a way to seal ruptured membranes, to reseal ruptured membranes. And it just didn't go anywhere. But we need an obstetrical technologies to actually do something, intervene and prevent. And we diagnose pretty well. We intervene after the baby's born, but we don't in pregnancy. And nobody wants us, the drug companies don't let us test drugs and test things on pregnant women. Most pregnant women don't want to be tested on.
Right. Yeah, for sure.
But no, I think that we just need we need a breakthrough in obstetrics. We need a breakthrough that actually does something that actually prevents. They have breakthrough to make people pregnant in the infertility world, but we don't have no breakthroughs once you're pregnant to prevent these very common occurrences like preeclampsia. That's my dream.
No, I love hearing people dream a little bit, because I think it lets us know, things that were not possible 20 years ago will be possible in 20 years, and how that can change the face of neonatology. So, Dr. Berry, I could speak to you for hours, but you've got to go serve. You got to go serve patients. But thank you so much for the gift of sharing with us about preeclampsia and really diving deep. I'm really grateful.
Oh, you're very welcome. It is my pleasure, and I will take time anytime to talk to you about any subject. So I just love doing this and helping educate people to bring it out. Let's no secrets here. Like I said, I want everybody, all of my patients and all the people listening, to know what I know.
Thanks, y'all, for listening to NICU Heroes. If you enjoyed today's episode, please don't be shy, y'all. You can share it, you can subscribe, and you can most certainly review it. We would love your reviews. It's how we reach more NICU professionals. I'll see y'all next time.